Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. Now, this is a build-up of the case study we discussed just last week, and this is how it goes. Following the surgical removal of the right submandibular gland, the patient who no longer this time around produce adequate saliva. Number two, there was also reduction in, of course, the general sensation in the floor of the mouth as well as the anterior to tertius portion of the tongue. And importantly, there was reduction in taste sensation to, of course, the taste sensation carried from the anterior to tertius portion of the tongue, except that of circumvallate papillae. But one important thing I want to make out over here is that in the case study, what happens was that during the skin incision, as far as these nerves, major mandibular branch of the facial nerve, and of course the cervical branch of the facial nerve, they are concerned, during the skin incision, it was uneventful. So there was no injury to, of course, the major mandibular branch, nor for the cervical branch of the facial nerve. In other words, of course, regarding the wrinkling of the neck, no problem with that. And also, elevation of the chin part, there was no problem with that. Depression of, right angle of the mouth together with, of course, the right lower lip, there was no, problem with that. However, in the case study, what we find is that this patient has reduction in saliva production, number one. Not only that, this patient, there's that kind of loss or minimal, sensation carried from, of course, the floor of the mouth together with the anterior to tertius portion of the tongue, together with, of course, reduced, taste sensation from, of course, the anterior to tertius portion of the tongue, except that of circumvallate papillae. So the first thing is that what structure, was injured in the submandibular gland area that resulted in this, manifestation, these symptoms. That's number one. Number two, what other nerve could have been injured in the process? And my friends, what will be the clinical manifestation, over there, and how you test for this, injured nerve? So this is the case study that we have right before us. Now the first thing is that last week we discussed, the nerves that are liable to getting injured when you are making the skin incision to get into, the submandibular area. We said they were, of course, the marginal mandibular branch of the facial nerve, and of course the cervical branch of the facial nerve. Now the good news is that in this case study, we are saying that during the skin incision, it was uneventful. In other words, these nerves were spared. However, after getting inside the submandibular area to remove the submandibular gland, the right submandibular gland, there was some kind of structures which are related to this submandibular gland, or that, and for that matter, injury to it. Now, based on the manifestations that we've discussed, the nerve that was injured is, of course, the lingual nerve. Now, lingual nerve relates superior to, of course, the submandibular gland and its duct, that's the Wharton's duct. That's what we see. So it's in a close proximity with it, and that is why it is likely that if you don't take care iatrogenically, this lingual nerve could be injured. Now, one thing we understand about the lingual nerve is that the lingual nerve is responsible for carrying, this time around, general sensation from the floor of the mouth together with, of course, the anterior to tertius portion of the tongue. So for this reason, lingual nerve, once it is injured over there, then there will be that kind of reduction in, of course, the carrying of sensation from the floor of the mouth together with, of course, the anterior to tertius portion of the tongue. That one, no problem with that. But the question goes on to say that this patient has reduction in saliva production as well as loss or reduction in taste sensation, the gustation, from, of course, the anterior to tertius portion of the tongue, except that of circumvallate papillae. And my friend, that's where we need to think about it. Lingual nerve is not responsible for, of course, supplying giving secretomotor fibers to supply the submandibular gland and of course the sublingual glands. Lingual nerve again is not responsible for carrying taste from the anterior to tertiary portion of the tongue, my friends, but something happens. The nerve that is responsible for doing these two things I discussed is, my friends, the cauda tympani branch of the facial nerve. Cauda tympani branch of the facial nerve. So then the question we ask ourselves is that, is the cauda tympani branch of the facial nerve, okay, also injured in the process where the lingual nerve is also injured? My friend, the answer is no. However, the fibers, okay, of cauda tympani branch of the facial nerve reach the submandibular gland and sublingual gland, yes, supplying them so that salivation, yes, will be maximum. Okay, that's number one. And it's also responsible for carrying, the special sensation by way of taste from the anterior to tertiary portion of the tongue, except that of circumvallate papillae. And so then the question is, what is it? And so because this, nerve, cauda tympani branch of the facial nerve, through hitchhiking, okay, using, of course, this lingual nerve, whenever the lingual nerve is injured, then it means that invariably the fibers which is running through it by way of the cauda tympani branch of the facial nerve will also be injured. And my friend, that is why you'll be seeing these clinical, manifestations. Understand that lingual nerve is not a branch of the facial nerve. It's actually a branch of the, it's actually coming from the posterior division of what we call the mandibular nerve. So it has nothing to do with facial nerve. Meanwhile, this branch of the facial nerve, which we are calling cauda tympani, uses the lingual nerve as vehicle to reach its destination. Okay, so that's one thing I want you to understand. Now, going on, it says what other nerve could have been injured? My friend, the other nerve that could be injured in the submandibular area, this time right, it relates to the lower aspects. Okay, as I said, related to the upper part, or upper portion of what we call the submandibular gland. Okay, together with its duct, Watson's duct, it's not called the lingual nerve. This time lower, related, inferior to it, my friends, is what we call this time around the hypoglossal nerve. So in other words, the other nerve that could be injured during the removal, surgical removal of the submandibular gland, this time around to the right side, is the right hypoglossal nerve. And so for this reason, what is going to be the manifestation? Remember, the first thing that is going to happen is that there's going to be atrophy of the tongue. The reason is that if you look at the tongue is a muscular, glandular organ. Yes, full of, minor salivary glands in there. Okay, but what we see is that skeletal muscle fibers move in different directions. Okay, and then embedded within them we have these minor salivary glands. But of course, I'm talking about the lingual, glands. Okay, so one thing I want you to understand is that for this reason, remember that whether it is intrinsic muscle or extrinsic muscle of the tongue, yes, except that of palatal-glossus muscle, you'll be supplied by, of course, the hypoglossal nerve. And so for this reason, the tongue, because the muscle, the intrinsic muscles are not getting the nerve supply, they will undergo atrophy. So the tongue will shrink in size. Now, not only that, if you ask the patient, okay, as far as tongue movement, okay, is concerned, if you ask the patient that maybe, change the shape of the tongue, which is done by the intrinsic muscle, it will be difficult. Okay, there will be that difficulty. So the patient cannot do that. Something like, all these movements that either make the tongue bulky or making it slender, it cannot be it cannot work. So changing the shape together with the position, there will be difficulty. And so the clinical test that you perform to assess the integrity of the right hypoglossal nerve, yes, is this time around, you ask the patient to flick out the tongue. So, for instance, you ask the patient, okay, to bring out the tongue. Now, in bringing the tongue, remember that this time we said the surgery was to the right submandibular gland. And so the one where it's likely going to be injured is the right hypoglossal nerve. So for this reason, there will be that kind of tongue deviation towards the right side. So there will be ipsilateral deviation of the tongue towards the side where there is dilatation. Yes, that's what is going to happen because of the unopposed action by the other, extrinsic muscles of the tongue. And importantly, I'm talking about the largest muscle, the fan-shaped muscle, genioglossus muscle. That is of what the safety muscle of the tongue, the one which helps your tongue, so that you don't deglute your own tongue. So it means that this muscle is responsible for, of course, protrusion of the tongue, bringing it out. And so in bringing it out, if you see that the tongue has deviated okay, has deviated towards of what this time around the right side, then it means that the nerve that is injured is of what the right hypoglossal nerve. My friends, this is what I have for you today, and I believe you find this helpful. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.